Hey there, welcome back to another episode of Owens Recovery Science Podcast. This is Johnny Owens. Today we've got our Speaking with the Experts podcast, and we're going to discuss soccer, or if you're on the other side of the pond or outside the U.S., I guess you guys call it football. But anyways, it's going to be a good one. We're going to talk about blood flow restriction applications for the soccer athlete for recovery from injuries, recovery post-games, and even some performance stuff. I've got some good friends and great guests on today. Reade Whitney from the Chicago Fire. I've got Paul Lombardo from the Sounders Football Club up in Seattle. And I have Kurt Andrews with Sporting KC, all from the MLS. They've been doing BFR for quite some time now, and they've got some great insights. So hope everyone enjoys it. Here we go.
This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, and welcome back to another Owens Recovery Science Podcast. I'm super stoked about today's podcast because we get to talk a little soccer, a sport that's near and dear to my heart. I love it, and being from West Texas, took a lot of ridicule in loving soccer when all it was football. So today's going to be a fun talk, and I got some experts from here in the United States working in the MLS with us today, and so I've got Reade Whitney, who I've known for a while, and he's out in Chicago with the Chicago Fire. Just to read his bio, he's in his third year with the Chicago Fire. It's longer than that, right, Reade? At this point. Third year?
This the third year with this team.
Third year with this team, okay. And then before you were with FC Dallas. He's got a Master of Science in Kinese and Rehab from freaking University of Hawaii, dude. Nice.
It was not the worst place to be.
Yeah, okay.
I'd say that.
Bachelor of Science degree in athletic training at the University of Tampa. This is such a Reade sentence here. He loves his girlfriend, Liana, ultra running, and his beard, and pushing the boundaries of the profession through an integrated use of modern technology and progressive rehab methods. So I'm glad you put your girlfriend before your beard. So that's good, man.
It was a strategic choice.
Game time decision, but it was a smart one.
Hey, you need to update that, though. That's a fiancé now.
Oh, fiancé. There you go.
That's true.
Yeah, get on the site and change that.
I don't speak French.
Oh.
Then we have Paul Lombardo. He's in his 9th year in the MLS, his 5th year with the Seattle Sounders up in the great Northwest. He's the lead ATC up there. His previous work in MLS was 3 years at FC Dallas. As I say, all good things come out of Texas. His responsibilities include assisting in all aspects of the medical care, injury prevention, treatment and rehab, and overall well-being of all the first-team players. His mission is to use his skills as an AT to help and heal professional athletes so they can perform at their highest potential. Paul went to University of Nevada, Las Vegas, which is another one of those colleges I wish I would have tried out at least for a year or two to see how it went. Bachelor of Science in Athletic Training, and has a Master's of Science in Rehab. Masters of Science in Rehab Sciences from California University of Pennsylvania. So thanks for coming on, Paul, as well. And then we have Kurt representing the Midwest as well from Sporting KC. He's the Director of Sports Medicine and oversees the club's technical staff. He's a Michigan native, arrives in KC after 6 seasons at the LA Galaxy, during which time he was part of 2 MLS Cup championships. He had to throw that in there. He's participated in MLS Soccer's annual medical symposium in each of the past 7 years, also completing U.S. Soccer's recognized 2 Recover Concussion Awareness Program. He's got his Bachelor's of Science in Exercise Science and a Master's of Athletic Training, and also National Athletic Trainers Association, National Academy of Sports Medicine, and previously at Exos, among other national organizations. So, Kurt, thanks for coming on as well, man.
Johnny, thanks for having me.
Yeah, and as we mentioned, you win the best hair award of the entire podcast today. So cool. So this is going to be good, man. So I'd love to talk sports specific with blood flow restriction, and I'm kind of hoping to go along a continuum here from what you guys are doing with it clinically to get players back after injury, maybe what you're doing for kind of performance, and then this kind of catch-all bucket, which I hate the term, it needs a better definition, but recovery, or restoring players back to baseline quickly to get them ready for the next match, and then any other kind of things you're looking out there, injury prevention or stuff like that. So I guess, I'm not in your world, and a lot of what we've done in BFR has been up to this point with the NFL and the NBA and MLB, totally different kind of sports than soccer. So from an injury perspective, you guys just kind of break down like what you guys see throughout the season, what's your kind of nagging things you deal with all the time?
I'd say for us, up in the Northwest, any soccer lower extremity sport, basically, soft tissue injuries tend to be the most seen and dealt with. For a soccer player, as a former soccer player, you see things that you normally don't see all the time, but those, the ankle injuries, the knee injuries and stuff like that. It is a contact sport, so you do see some of those contusion type of injuries. But the big one is the soft tissue for us, I would say.
Yeah, to echo off that, you're going to get a lot of adductor, hamstring, calf, quad injuries for the most part. Something we deal with quite often too are your tendinopathies or overuse injuries. Obviously dealing with not only the first club or the first team, but you look at your USL club and obviously your academy kids as well. You get a plethora of lower limb injuries, a lot of them being overuse, and that's kind of something we all along this continuum of performance have to work alongside performance staff and try to mitigate those types of injuries as well.
I think the amount of load management injuries is kind of something I'm most interested in. Is they've been categorized as overuse, but really it's just misuse. I think a lot of times, if you know the guy's training load, you can really understand if they are overused relative to somebody else who is underused, and then it is acutely overused. So how you can, build people up or maintain them or whatever you need to do based on if they suffer from some of those OLD injuries, depending on the team.
Yeah.
So that's becoming more and more important with some of those hormonal levels that may be starting to taper off as guys get older.
How much are you guys tracking in the MLS using technology to measure load and things like that? Every professional organization seems to be looking for the latest and greatest technology to track these things, and especially over in Europe, it seems like with the groups we're working with. Is that pretty big in the MLS as well?
Yeah, I would say so. For us, we use, I don't want to plug any particular type of company, but we do use a load program or a load device to track players' distance, movement, counterbalance stuff, all that kind of is being used throughout the year. But again, that's also player acceptance of using it. That's a big one we tend to find is players tend not to want to wear it during a game. So we can't always continually get them every day or every time they do any kind of exercise or on any kind of field work, because sometimes they choose not to wear it. That's another battle for us. I don't know about for the rest of the two on the talk here, but
the lack of compliance will defeat the purpose of those kind of programs. And then what we were seeing, and reported, especially in the early days, is just this data overload. Is you're just getting so much from that you start to wonder, what you can even do with it or what you could do to change, really. What does it look like for your schedules? Just to kind of break down so we know what kind of load management you're looking at from a game perspective to a training perspective. Take me through like a typical work week for you guys.
Go ahead, Kurt. You're the one with the CONCACAF, so you have a little more games going on.
Obviously every organization is going to be a little bit different. All coaches have different tactical approaches in terms of how they prepare for their weeks as well. For us, it's been kind of a hectic preseason and even beginning of the season being in Champions League. One of the big things was the first Champions League game was in Toluca, which is just under 9,000 feet in elevation. So for us, it was in our preseason and our approach is getting guys intense, kind of getting them acclimated to what it would be like to play. And then obviously the week before we went to Toluca, we trained in Albuquerque. So they were able to expose them with an actual physical load rather than just sleeping at the appropriate elevation or at an elevation we want them at. For us, it's been pretty much 3 games a week where you play a Sunday, Wednesday, Saturday, or a Sunday, Wednesday, Sunday. And then it's just in your load management or in your preparation for the next game, it's just a recover, prepare, play, and it's easy for the 11 to 14 that are kind of getting actual minutes. The trick is, how do you manage the load of the players that are 14 through 22 or 24, depending on how big your roster is. So 1 through 11 are getting constant minutes if you're not rotating your lineups. And again, it's going to be your approach and how you want to play different opponents. And that comes down to us and performance staff, also with technical staff and the coaches, and developing game plans for individuals and how we want to get them through each week.
Pretty much the same across the board for the group here then, I imagine.
Yeah, I mean, for us, we have the same, managing those players, managing the guys that aren't getting the minutes that the first 11 maybe be getting. And again, it's just compliance. Can we get those guys to do what we need them to do to get those numbers we need to help them manage?
Yeah.
Some of the biggest thing is guys that maybe didn't do anything in the off season versus guys who maybe did way too much, and getting them back onto a somewhat regular training schedule and travel schedule. We did a preseason in Europe this year. So guys coming back, and then we went back to the East Coast, and we've been doing lots of travel for that without necessarily the same type of game. So it was our travel schedule has been relatively easy once we started games, but just getting guys into a normal routine, getting their families into routines, getting them to know where the stadium is, how long traffic is, things like that, all affects how much time they're able to dedicate to their recovery, preparation, and then gameplay. There's so many intangibles that we just try to line up to take the stress off.
From what you can control in your clinic or locker room for recovery, taking out the mental components that we know are a problem in logistics, what are your go-tos, or you're saying, this is what I want to do to help someone physiologically recover? And we can start spinning this into ischemic preconditioning, blood flow restriction, everything else that you might do, just to kind of see from a soccer perspective. Post-game, the guy's hurting. Day later, the guy's sore. Whatever, I got a game coming up. Are you specifically looking at anything treatment-wise?
For us, I like to throw on bilateral cuffs on guys and get them on the bike. Again, educating these guys on what we're trying to do, what it's trying to do, and trying to speak to them in a less, I guess, scientific way to get them to understand it is another key thing to think about. But we get them on. I've got a couple guys personally that they have gotten on and tried it. They liked it and they continue to do it. But again, it's a hit or miss. I mean, it's not like we don't have a specific regimen or a specific time to do it. They're just like, hey, can I do some BFR today? I'm like, oh, okay, yeah, let's go. Let's do it. Right. There's no, doesn't, from the all the papers and stuff we've read or been presented, there's really no residual, to me, I've found there's no residual soreness or anything from guys doing it after a game or even after a hard training session. And it helps, I think, in their mind, hey, I can still do something
right,
without getting myself hurt or being any issue the next day.
Yeah. How about you guys, Reade?
I think the intensity that not the intensity, sorry, the pressure that gets applied when we have guys like the day after a game doing a regen ride on the bike or a regen elliptical, something low impact that you would do 15 or 20 minutes. Well, now I can throw the cups on them, and that's a good introduction if they've never done it. I know 80% is usually what you'd need for lower extremity, but I'll start them at 65, 70, so then they don't hate me.
Yeah.
It's their first exposure is, okay, wow, that was really difficult, but it's tolerable. And then they get off and I say, text me this afternoon, 4 or 5 hours from now, let me know how you feel. And oddly enough, a lot of them are like, hey, I usually need to crash and have a nap the next day. I feel better. My legs are not as heavy. I actually went and played at the park with my kids, things like that they would normally not have felt with just a 20-minute random, okay, I'm going to pedal at 50 watts and don't get anything out of it because it's just not quite enough stimulus.
Right.
But you can have that same kind of mechanical stress and get a much bigger stimulus.
Yeah.
And they end up thanking us later.
Yeah. Yeah.
I'd say, here on our regen days, the guys that played significant minutes, so more than 60 minutes, they have a 3x6 or 3x8 run as their regen session. Something that we've kind of toyed around with, and obviously with BFR and doing it in the team setting, it's the applicability in having a numerous amount of units to do it. So that's where it becomes kind of difficult in our setting, just from a financial perspective. But is even doing BFR in a passive state, you hook them up to a complex machine or some sort of stimulation device, just have them on the table, you occlude pressure, and then obviously just have them sit there for a 20-25 minute cycle. And after the 20-minute session, and then even 12-24 hours later, they can feel a difference in terms of feeling lighter, feeling fresher, feeling, regenerated or more regenerated than what they were. So it's kind of something we've been toying around with here, obviously within the means that we're allowed, because you can do about one person per session. So
yeah, it's something it's almost like case studies right now. And I think there's this kind of spectrum of recovery that we're looking at now. And Dr. Patterson and I presented at Combined Sections. He's kind of the IPC, one of the IPC experts out there. And, and it's your most basic, if you need to do it, at the most passive level, is just BFR passively or ischemic precondition. It seems like if you're going to ischemic precondition, you probably have to go to full occlusion. And like Reade said, when you blast someone full occlusion the first time, they might punch you in the face and never come back. And that's always the message you want to get out there too. It's not like you have to start everyone at 80%. We do all these total joint trials now, and I'm not starting Grandma Smith at 80%. We'll build her up to it, but she's not going to tolerate it. And athletes sometimes are like Grandma Smiths, as we know, where they're very sensitive. And then as they get used to occlusion, then the next level of passive is with a complex or E-stim or something like that. And it seems like maybe ischemic preconditioning is what can maybe blunt muscle damage potentially. We're not sure. There's a lot of things we're looking at. So if you're slowing muscle damage, then as you start getting some sort of active contraction with it, like E-stim at the lowest level, then the next thing would be, like Paul said, exercise with it. Then you're getting maybe the muscle protein synthetic response. So if you get this like 1-2 punch of I've blunted some muscle damage and I've got muscle protein synthesis, then from a muscles perspective, you've really helped a muscle recover quite a bit. And so that's what we're trying to look at across the leagues here is whatever, the baseball guys. It's funny because baseball was so antiquated in a lot of the stuff they do. And one of the things they do though is they kind of have these, built-in lore post like pitchers like arm exercises, and sitting out there with a 1 or 2 pound weight and some bands doing stuff, but then throwing cuffs on and having those guys do it. It seems like we're getting a lot of anecdotal reports and now even some, an MLB spring training study that's going on right now of seeing these guys are like, man, my arm feels much better the next day. So it'll be interesting to see in soccer, is there a faster recovery that's measurable? And it would be such an easy thing to look at, I think, in your sport is, just looking at maybe a sprint time the next day or two of could these guys get back to maybe what their baseline sprint is? Did this get them to get that power back a little bit quicker? Or with some of your wearable technology, that you're talking about, Paul?
Yeah, that you hit right nail on the head there with the wearable technology. You can tell if a guy, hit some high speeds during a training session where he normally would not be after 2 days after or a day after, where a guy's like, I'm fully recovered. I feel fresh. And you say, oh man, you hit your 80%, and usually you're at 60 or something like that on these days or something like that. Give or take, the numbers can be different, but again, it's just you get some sort of percentage or some sort of hard number. A player reacts to that. They're like, "Oh, hey, you gave me a hard number here, and I can do this," and it just helps them recover even more, because a lot of it's also that mental aspect of, hey, can I go again and can I play a game in 72 hours or something like that. And you know what happens.
Yeah, that's when you get the buy-in too. And it's like, here's the numbers, man. You hit it. I think that little bit of suffering that you went through doing this, it got you back this to your numbers. That's the sell. You got to sell it. Sometimes it's hard work.
I mean, Reade's a great seller about this stuff, though. He sold me. I mean, when I first started talking about it. So
I just like talking about it because I've seen it work. So,
what about analgesia? So using it for any nagging pain or stuff like that. That's kind of big with a lot of the NBA folks right now. I'm speaking of the NBA Combine, and that's something I'm talking on. I'm actually reviewing some grants that are submitted for BFR and analgesia. So, have you guys done that for anyone that's got like a nagging injury? Pre-game, pre-practice, or anything at all, or thought about it at all, or seen people who had an injury you've done it on, they're like, man, my pain is much less or worse.
I think the analgesic effects work better with players that are the type that I feel better once I warm up type of conditions. Mm-hmm. Or once I'm playing the game, not just exercising, then I don't think about it, because they had to have used BFR and worked to an intensity where they're pushing themselves hard doing it. Mm-hmm. And then that sort of discomfort, kind of central governor discomfort that usually says, yeah, I need to deflate now. Uh-huh. I'm holding my breath. I feel like I have the noose on. I'm like going underwater and I'm only 6 minutes in. That person that's done that once or twice gets a much better analgesic effect. And I think it's just because I liken it to, okay, now you have Formula One car RPM range because you've put it up here in the intensity that you push yourself, as opposed to NASCAR RPM range, where that's where your pain is usually able to go before you decide I need to stop. Mm-hmm. So it kind of expands your zone because you're used to a discomfort. Mm-hmm. But I think there's the other things too with, okay, you're going to get this big rush of blood afterwards. You're going to get extra oxygen delivery to some of those smaller sensitive nerves that are near a pain site. Mm-hmm. And the combination of the two ends up being the biggest effect.
Have you done it pre-game at all, Reade?
Not pre-game, but we've done it pre-scrimmage.
Yeah.
There's still some hesitation of it. They're worried it may make them tired, not from the player.
Yeah.
The players know that it doesn't make them tired, but from other staff that may be concerned about that.
Yeah.
Yeah, and plus when you talk about buy-in, you don't want to have done a BFR session before a game or before a scrimmage or whatever, and something goes wrong to where that player then blames BFR. And so it's just in their mental preparation, you don't want to add a stimulus that'll kind of shy them away from actually doing something that's beneficial to them.
Yep, for sure. So
I was going to mention some of our goalkeepers tend to work too hard in the gym or in sessions, and they love to train extra hours compared to every other player for some reason. They also play the position where they can only tie or lose. So that's weird.
Yeah.
I think that just getting, for example, one of our goalkeepers now used to lift heavy twice a week because he knows that's what he would do to maintain his strength during the season. And that was his habit, all these things. Well, I've convinced him to knock 2 sets off per day and do 1 BFR exercise on each of those days. And then after that, do the full occlusion kind of 5 minutes, 1 minute for 4 or 5 rounds. Mm-hmm. And he feels so much more fresh the day before a game, so much more just on it on game morning, because we've had these noon games. He's like, I'm not going to change this. This is my go-to now.
Nice.
And as an older player, he's now reduced his joint load overall by over 20% just in those 2 lifting sessions that he took out.
Yeah.
So I also haven't had to treat him for any back pain. So that's nice.
Yeah, exactly.
To jump on that real quick though, like you said, Reade, like, you have 2 weight sessions during the day or during the week. I mean, we can barely, some teams can barely get us a weight session in once a week because of schedules and stuff like that. So if you, and as the BFR is so small and so easy to use, I mean, for ones who are trained in it to put it on someone and have them do simple exercises, I think they just get a little more benefit out of it. And extra after that load has been taken off of them, as an example for a goalkeeper, landing completely on their sides, on their back, wherever they do, that impact, it does take some toll on them. And if you can lessen that, I think you buy them in 100%.
Yeah. Yeah, there's definitely these load intolerance, and even like Reade threw in, then they get these nagging back pains and soreness and all that sort of stuff. That especially in the NFL, we've seen that with some of these veteran players, or they've had a back issue, or like you said, Paul, I mean, schedules where you travel every 2 or 3 days. How do you really work in a true lifting session and can control all the variables that go along with that? But yeah, the portability of this is pretty nice from that perspective. So
agreed.
Let's move into kind of some clinical and injury and rehab type stuff. So you guys maybe can just let's talk about cases where you've used it for certain soccer injuries, non-surgical, surgical, whatever. So can you guys think of any that might be interesting to discuss?
Yeah, I've used it on ACLs, of course, because post-surgery, actually even pre-surgery, because of their prehab to get them strength up, and I mean, just like you normally would in the past, build their strength up before they had surgery. We use that quite a bit. We use that at least 3 times a week prior to the player's surgery, and then post-surgery, we've probably used it on a recovery day or on a strength day on top of his normal rehab exercises, and it's been done really well for him. He's liked it. He's bought into it. Again, he doesn't like it on days when he's not in the mood. Yeah. But our players tend to be in moods, and you try to talk them into doing something, they'll do it, but they won't do it. They'll do it reluctantly. But ACL pretty much for us, and then a little bit meniscus injuries and stuff like that. I've used it on for us.
When do you start post-surgical?
It depends. I would say I was using it probably 10 days.
10 days.
10 days post.
After follow-up, stitches are out is kind of your typical probably?
Yeah, probably. I mean, depends on the orthopedic doctor, of course, how they feel about it. And is that orthopedic doctor sold on BFR as well? We've had a couple doctors in the past like kind of are hesitant with it, and then we just have to sell them as well.
Right.
So.
Right. How about you, Reade?
With the doctors that are sold, I have it on their arms the day after and their other leg the day after, and making them pedal the bike with one leg for ACL, for example, like just they're sitting on a recumbent bike and moving the other leg, and they hate me. But then I've actually had a guy's girlfriend call and say he's in a better mood. He worked out, like all these kind of things. And then they also stop taking their pain medicine sooner because they're like getting some exercise endorphins. They feel like a normal person again. They're not just sitting on the couch doing nothing.
Yeah.
For 3 days, 7 days, whatever.
Yeah.
But yeah, same thing. Once the stitches are out, regardless of the procedure, then that's when it goes on the other leg.
Okay.
And build them up, start with the lower pressure, things like that. That way they buy in sooner.
Yeah. And there are a couple of, these aren't BFR orthopedic papers, but surgical papers where they've just done inflation bouts pre-surgical. For one was for gallbladder surgery, one was for total joints, and significantly less pain post-surgery and significantly less narcotic use in both of those. So again, this, maybe being in a better mood and being off narcotics could potentially be supported by what's already out there in the literature. Some hypoxic event, maybe just the old hammer on your finger, you don't feel your knee anymore. All they felt was that damn tourniquet annoying them. Who knows? Kurt, what about you, man? Any specific cases?
Yeah, I've used it with Liz Frank injury in the past. And again, that was basically immediately when the physician was okay with that and then making sure the stitches or the wound was closed. Like Reade said, you get creative and you put it on the other leg and you figure out ways to incorporate it as early as possible, keeping in mind occlusion pressures and trying to get buy-in as soon as possible. We're kind of at the end stages of a condo defect where we had an Oates procedure. And that was an interesting case just in general, but, it's kind of like talking about different cultures and getting buy-in and even getting people who, if you look at the American population in soccer, they are used to the gym. You look at the Latin population and some other, the gym is not in this soccer realm of the soccer world.
Yeah.
So getting them bought into using blood flow on top of getting them in the gym is a challenge. But it was a good experience, and obviously it really helped with the BFR helped in minimizing atrophy prior to surgery. Once he had with the Oates procedure, there's two surgeries scheduled, one with the go and clean up, and then obviously waiting for the donor for that second surgery. So in that 6-week waiting period and just really hammering BFR with all of his prehab leading into the second surgery, it was incredibly beneficial for him in minimizing how much atrophy he had post the second surgery. So we had a lot of success with that. We typically use BFR in all acute stages. It doesn't matter if it's a sprain or strain. We try to get him on it day number 1 following an injury. So we have kind of really good success with that and understanding of how we want to use it. So it's been a really good adjunct for us here.
Nice. Good stuff, man. So you guys, when do you transition off? Like, so post injury, post surgery, you've been using BFR because you probably couldn't use load, maybe going after a specific pathway or something. When's your decision making that, okay, I'm going to start transitioning into moderate loads, traditional loads? Do you just kind of move along until it seems like they can handle load? Do you have a specific thing you look at? We get that, like, when are you guys transitioning post-surgical?
Go ahead, Reade. I think you have an answer for that one.
I start them literally as soon as possible with a progressive load.
Mm-hmm.
But I will have them do it with the BFR on still, just for a normal kind of a 3 sets of 8, 4 sets of 8 rep range, and then it decreases as the weight goes up. But I want them to get used to just having the cuff on, because then I end up transitioning, say, if they had a hamstring or a groin, I have them do Copenhagen's with it on, or I have them do Nordics, but band assisted with it on.
Yeah.
So they'll do 75 band assisted Nordics. So it helps them, but it's helping, so they're only doing 30% of what a Nordic would normally feel like.
Yeah.
But then the next day and the day after that, they don't have the Nordic soreness.
Yeah.
But they're getting used to that contraction. They're getting used to like being able to just have this capacity to work for long periods of time.
Yeah.
Because a half is 45, 50 minutes twice.
Right.
So I try to make the sessions last 90 minutes.
Right.
Even if it's a low intensity, and then I just gradually up the intensity. And that goes in terms of load or speed or less rest.
Right.
But it almost always, they still end up doing BFR 3 times a week.
Okay.
Yeah, I would follow the same. We do 3 times a week. It could be pre-exercise or pre-work or post-work movements. But again, short arc quads, depending on what type of injury, would say if they're in ACL or stuff like that, short arc quads, long arc quads, loaded, unloaded. It depends on what they also, the doctor is like, hey, I want this person to be doing loaded stuff now. Okay, great. I'll put the cuff on them, or I'll do it with this and then take off, use 30% of the weight or wherever it may be, or even just a wrist or cuff weight or something like that, and still have them do these exercises. And it's just again, you're building strength.
Right.
That's what we want. We want to get them that strength because their knee wasn't as strong before. So there had to have been an issue, or they just unlucky type of injury. But again, you want that strength so that then they have full confidence in that ligament or knee or wherever it may be.
Right. Right.
I think the application is obviously going to depend on the injury. I would probably say, and I can assume that all 3 or 4 of us will agree, that when an injury occurs, we kind of have an understanding of timeline or what is our expected time that a person will miss. here with our BFR stuff, we'll typically have them do it 5 days a week. Again, that's dependent on schedule. We're afforded the luxury of having Chris Wolbert, who's our physical therapist here. So even when we're away, we can get a 6-session in on a Saturday if it's an away game. Whether they're doing some sort of biking as a warm-up with BFR, whether they're doing some sort of BFR burnout at the end of the session. We get creative with how we use it. Obviously, you start to talk about the transition of BFR in an endurance state and then actually mechanically loading tissue, and that's a conversation we have with our performance staff or with Chris, whoever's going to be handling the gym sessions, and kind of what we're trying to achieve that day. So it has to be, a collaborative process with the departments in terms of how we use it and when we use it, and make sure it makes sense, within what we're trying to achieve that day.
Yeah. Yeah, and that's what's beautiful in your world. What we had in our world, the DoD and the other pro teams, is this ability to do it as a prehab to surgery or surgery, post surgery, to be able to go in and Reade's jumping rope again. It sounds like post surgery.
I'm working out without working out.
Yeah, it's nice.
There you go.
Post surgery, the more you can get them in, the better. So when you're using almost no load and passive, it seems like a daily, sometimes even twice a day, is probably best practice, we think. And then tapering down to that 3 times a week after they start to get in that 20 to 30% 1RM range. If you were to kind of dial up what's the perfect kind of BFR progressions, that's it. Most clinicians out in the civilian sectors, non-sports, don't have that luxury. But in y'all's world, getting that kind of volume in is great. So let's discuss soft tissue then, because this is something really has no research that's been published yet with BFR and a soft tissue injury like a hamstring, groin. It's been done a whole lot, and we've got a lot of anecdotal. We got some pretty positive results down at the University of Florida years ago, and wrote up a little kind of fluff case paper, training and conditioning journal. So not a real peer review PubMed, but just kind of we wanted to get out there that we saw these results. And then a couple of NFL teams, same thing. And Reade, it was kind of 2 things. From one was actually doing it with a Nordic type setup, which at first we're like, holy hell, that sounds just freaking god awful. But it had to be unloaded. So I think that's the key. Most people aren't going to bust out 75 Nordics with a cuff on and and tell about it. We've got to caution people with that. There was a wrap paper where they did maximum eccentric contractions on the plantar flexors, and when they had a cuff on, they completely mitigated muscle damage. So they did kind of what these eccentric kind of heavy, just crush a muscle loading programs were, but cuffed it and blunted the muscle damage response. So there is that thought, especially Reade, as you're talking about progressing these Copenhagens or Nordics or whatever freaking European country you want to call them nowadays, to do that with it. But then also the nagging, what we really saw, these nagging kind of repetitive hamstring injuries responded really well to it, and kind of cleaned them up where the players didn't feel that tightness back there anymore. They could actually do the Nordics without the kind of miserableness that they would have from it. So from a soft tissue perspective, you guys kind of give me your takes if you've done some with it for a hamstring, for a quad, for an adductor, when you would start, kind of what your protocol might be, and just roll from there.
I think I can be a little bit more clear about some of that transition point we talked about before, was once they can get through the kind of 30 and 3 sets of 15 scheme with a body weight type exercise, if they're doing squats or something like that, or they're down in that 10 or 20% 1RM resistance. Then once they get up to 40, 50% 1RM resistance and can still do the 75 reps, then I take away BFR and I go to things that will do more. Okay, we need this much load for tendon. We need this much load mechanically.
Yep.
But soft tissue wise, once they can do kind of those band assisted things, I think they need to build up enough pressure distal to the cuff, because I think that outward pressure from within the blood vessels and all of that fluid that's trapped ends up causing enough mechanical stress that some of those, I didn't feel that grabbing in my hamstring doing Nordics anymore. I don't feel that, like you said, it kind of cleans them up, whether that's the flush afterwards or that somehow mechanical stress from the fluid pressure within the tissue, I think is a big part of it. And once you kind of have that discontinuous fiber, you get less transduction like across the fibers. So if you can clean that up and get a straighter scar, a healthier scar, or just better mechanical transduction around the scar because of that fluid pressure helping align things, I think you end up getting a better outcome ultimately. Mm-hmm. And that can be, whether it is the fluid pressure or not, I'm not sure. That's just kind of where I think this is coming from, because there's no other factor at play that would be due to building up pressure in the muscle from restricting the blood flow.
Right.
Because I don't think it's the cuff physically pressing on the tissue and getting, like a floss band would do, any of that shear force. I think it's more the pressure from within the muscle filling with the blood and then has to glide.
Yeah, well, that's an acute response, and I think there is an acute response. We're also seeing this chronic change, which wouldn't be pressure related. That's more of there's an actual potential regenerative effect at the muscle, or something else. We don't know. That's this thing we've been really fascinated with is fibrosis management with this. Is can we slow, the TGF beta pathway and fibrosis through some of the things that have been identified to potentially happen when we do BFR, because one of the Achilles heels of a soft tissue injury in muscle is that you're going to produce scar, and that's what muscle does. Muscle doesn't like to just flat out regenerate; it likes to throw down scar as quickly as it can, and that provides stiffness to the muscle. If you're a caveman, that's great. If you are a high level athlete, a little bit of scar is pretty detrimental, and so. That, and we're hoping these fibrosis trials start to happen where we can get some actual imaging of that. And the problem is, man, there's just not a lot of grant money for a hamstring injury. So getting a big, well-funded soft tissue injury trial is going to take second fiddle to a bone trial or a diabetes trial or something like that. So we have to live a lot off anecdotals, it seems like. Paul, Kurt, your thoughts on any of that?
For me, to be honest with you, I really haven't, knock on wood, needed to use BFR on soft tissue lately, other than just, your tendinosis and stuff like that. But as a muscular use for it, we haven't needed to.
Good.
For us, which is great.
Yeah.
But again, it's something, again, talking with us four guys right now, I'm learning even more, learning how to apply even when, maybe it doesn't account for to use BFR or to use it. I was never really thinking about using it for soft tissue, to be honest with you. So, but again, but using the BFR with the soft tissue all makes sense. It's just, we just haven't needed to use it yet.
Yeah. What about you, Kurt?
Because your guys' data is so good.
Yeah.
It's all the wearables. It's the wearables.
Yeah,
They load manage them so well.
Yeah, exactly.
Kurt, your thoughts on any of that?
Yeah, to echo kind of what Reade is saying, obviously with BFR, there's a lot of theories in terms of metabolites that it produce, and we can assume why these things work. I don't know if we can, for 100% fact, say that they do. Anecdotally, I think we can all agree that they do within the clinical setting. For us, soft tissue injuries are prevalent, obviously, at all levels, whether it's first team, second team, or our academy system. We'll use it on all groups. My youngest academy kid is 12 years old, and then obviously I think my oldest guy's 33. So we've got a good age range of men and kids that we use this on. We try to apply it in as early as possible. You're trying to, whether you're going for the cellular swelling approach, whether you're trying to increase growth hormone. There's all reasons as to why we're doing this. And you're going to apply it in different stages of the healing process based on what we're trying to predicate or what we're trying to do in that stage. So again, it's just, you have to try to have a thorough understanding of what BFR is able to accomplish and figure out protocols, if you want to call them that, in terms of how you're going to use it within your setting. All three of us are in different teams and different organizations. We probably have similar thought processes in terms of how we want to use it. They're just going to be applied differently. We all have different players and their psychological approach to when, how much they want to use these. Big thing is education, and trying to empower them in terms of us telling them why we're using it and having them ask questions to us. It helps educate us more, because then we have to do more research in terms of why the BFR is working and what we want it to work for and how it's going to get them on the field faster. I mean, it's easy in this world to get guys to buy in, because to put a roof over their head and food on the table, they've got to be on the field or inside the white lines playing. So, I mean, they're kind of in the business of, they'll do literally anything sometimes to get on the field faster. And so it's kind of in our favor. And again, it's just when and how you use the BFR and whatever other approaches you're using in the rehab setting. Just to me, it just has to make sense.
Yep. A lot of clinical decision making for sure. And we're still figuring this all out. So do you guys all take care of kids at the academies, or is that primarily in your world, Kurt?
I know we do not. I was dealing with the first team. We don't have that many academy kids. We do have young kids that come up to our second division team, or our S2, or our Tacoma Defiance team, which has been rebranded. But other than that, we maybe 15 is our youngest that we see. I see.
I'll see all the ages, but it's mostly if there's something more complicated, not a run-of-the-mill ankle sprain or something, a re-injury, and just kind of look at the whole process of what maybe has happened, or where did a ball get dropped, or something, just where did something occur that maybe we can step in and say, okay, I can work with this kid for an hour on this day to make sure that the process is a little better, he knows his home exercise a little better, or something like that.
Cool. So the youngest, Kurt, you've done it on 12-year-old kid? At your place?
I can't say we haven't done it on a 12-year-old kid per se. I mean, that's the youngest athlete we have in our academy system. I'd say the youngest we've done it on 14 or 15 years old.
Yeah. That's a lot of questions nowadays. And soccer is such a youth sport in America, Is this okay on the adolescent athlete? The youngest that I know of that's been reported to us is 7 years old, which I just don't know how you got a 7-year-old. I've done it on my daughters, just messed around before, and they're 9 and 12, and they're just wigging out like freaking barbecued kittens. But it's been done. But that younger adolescent, not younger, but this like 12 to 16, pretty athlete. Maybe young female who tore her ACL. We've seen a ton on that. Even down here at our center, at the Center for the Intrepid, we would get to see the service members' kids at times if we had capacity, and they did extremely well. And getting muscle back on a kid and strength back on a kid is fantastic, because so many of these kids, we just send them back in the game weak. And I think that's just a crime. I wouldn't send my daughter back at 60, 70, 80% strength post ACL, potentially with a bone bruise, just to watch her get arthritis in a few years. And so I think the risk reward is really there. And a lot of times we just burn visits. The first couple months of rehab is all, the visits are primarily used up when you're just working on range and controlling pain and all that sort of stuff. Then when they finally are supposed to be able to start putting some load on and maybe get the muscle back, they're just released to the wolves, back to the coaches, and going and playing. So I think that's something that'll be interesting to see, especially in sports like soccer, where we see a lot of lower extremity injuries, ACLs just going left and right on these little kids. Does this become more and more accepted? There's not a single pediatric trial that's ongoing or study that's been published. We have a lot of anecdotals. And we have some of the big pediatric centers in the country that are doing it. Even, one that does, neurologic injuries, spinal cord injuries and things like that on little kids, that are doing it and seeing pretty positive results. But it'll be interesting to see, at some of these clinics that you guys might have your academy kids go to, is that accepted practice?
I think it just comes down to, do they have it? Do they have those devices? I mean, a lot of clinics around here would, at least in the Pacific Northwest, I haven't seen or heard, except for professional teams having these devices. I could be wrong. I don't know. Again, we don't get out that much because we're so stuck in our training rooms and stuff working. So I just don't. I couldn't answer that question for up here in the Northwest.
Yeah. The big question.
I know sorry.
Well, the question we had was the physis. Does it do something? Because we made a strong case about 4.5 years ago that it does positive adaptations to bone, and from that we got this, the biggest BFR study in the world right now, a femur fracture trial that we got grant funding for. That's not the primary aim, but we do think it makes changes on bone. And then we just had one of our papers from one of our research groups presented at the Academy meeting this weekend, showing post ACL that BFR significantly increased bone density in the BFR, ACL, femur, and tibia. And what was real fascinating from that study is the control limb was osteopenic, very osteopenic at 6 and 12 weeks post surgery, and that just disuse, the injury mechanism, everything. The bone just completely starts to look like an aged, old bone, which was really fascinating. So that's our first pediatric trial we're hoping to do. Actually, an animal model is look at what effects it might have on the physis. So far, nothing's been reported that there's been an issue, but that's something we have to clear up for a lot of these pediatric ortho docs.
I can say we had a player had a radial fracture, and he was, I want to say he was 15, and was in a cast he was in 2 casts. He was in a long one for 4 and then a short one for 4. And each time the cast was changed, the PA and then the physician were amazed that there was not very much play in the cast, because we had done 3 times a week just cell swelling on the arm. And then we had him ride the bike once a week. And he was like, your cast isn't loose. And I was like, well, we've been doing this. It was kind of a ask for forgiveness situation. And when he took off the second cast and tested his grip strength I had the kid doing like this in the cast, but it's not moving his arm or anything. He wasn't with the short cast doing curls. But I guess we could have. But he ended up he was 90% of his grip. Just by doing that. He of course did normal 15-year-old kid. He would still pick stuff up with the hand and whatever because it was in the cast. But he barely lost anything. And
that's the goal.
It matters so much in soccer, but that's huge for a kid.
Sure. Well, and then we learn, and what that matters for is the elderly Fuchs injury who atrophies like crazy. My mother-in-law broke her wrist years ago, and she still has a hard time opening a jar. And I always say this, I don't do BFR on my mother-in-law because I don't want that. She's an older Latino lady. But that is in that population really where if you can keep their atrophy at bay from a cell swelling protocol where you're just driving, hopefully something that's reducing atrophy, that's huge. We did have a wrist fracture study with primarily older patients. It was just presented at the American Hand Society where we did it on them. No ill effects from doing BFR while they're in cast immobilization. But it was a pilot. The primary aim was to make sure that we weren't having adverse events and what was it doing to their pain. And it significantly reduced their pain and increased all their self-reported functional scores in the BFR group. Doing exactly what you're doing, Reade. Cell swelling, just some kind of like wrist and finger stuff and some elbow motion.
I will say the interesting thing. he never said that his cast was itchy, which I thought was something interesting, because usually everyone's like, my arm is itchy.
Yeah.
And he never had that.
Oh, that's interesting. Some hyperemic effect or something. Yeah. What were you going to say, Kurt?
Yeah, we actually are kind of piloting something here. We got a guy who just recently had a scaphoid fracture. I think we all understand the shitty healing properties of that bone just in itself. And so the seriousness of, obviously, the longevity of it being a dominant hand, or, in post soccer, and actually using that thing for your simple daily functions, writing, brushing your teeth, using the remote, that kind of stuff. And so we've done a lot of kind of what you guys are talking about in low level and cellular swelling, just to help with keeping that thing bathed in some blood, trying to get some angiogenesis.
Yep.
Trying to improve cellular or blood flow to that bone to help give it a fighting chance. Obviously, you don't want to pin it. I mean, even pinning it can be unsuccessful. So we're seeing how the blood flow can help with him.
How far out are you now?
10 days.
Okay. Yeah, well, that'll be interesting to see. And so we have seen that quite a bit, primarily with the fifth Mets in football and basketball, these Jones fractures, and just trying to track changes there. Like you said, this angiogenic response, it's pretty straightforward. Hypoxia in a limb seems to promote angiogenesis. It starts from the bone, HIF-1A comes out, vascular endothelial growth factor comes out, and you get this angiogenic response. Probably has to happen with some sort of exercise, but not 100% sure. That's the magic question. And getting back to these whole pressure things, our ACL one that just came out and showed the bone became more dense from it, that was at 80% limb occlusion in all those subjects. So it was kind of the pressures we use. As we always say, you don't have to start there. You build up to it. It seems like it's pretty valuable. And then from Jeremy Lineke's lab and Dr. Mouser, who's not there now, they had a paper that recently came out. The angiogenic response was very, very similar to lift and heavy in a higher pressure. The lower pressure didn't have the same response as well. So this is, I think, as we start to, and that's what's great when we're all talking the same language, what pressures are you using, and when it's all kind of standardized, then we're hoping to lay out these protocols of, okay, we need to be at this pressure to get this angiogenic response for maybe getting the angiogenesis around these slow healing structures like that. And even, we're looking at this rotator cuff trial. What does it take to get a proximal effect, potentially, to get a collagen synthesis type healing response? So cool. Good stuff. So I guess this is Reade. I want to throw this one at you because it was one of your things. What do you think about why it takes people so long to come around to new things? Is it just because you're such a forward thinker, man? And
other than
I'm with you,
man. Other than complacency in general, I think it's because the way things get marketed to people in our position, or just to any first team staff member, essentially, they get told, hey, we know the pressure is really high for you guys to win. We're going to help give you an edge. This is the new latest, greatest. This is going to be the thing that helps your team win and get your guys back. Everything is the best.
Mm-hmm.
So when everything is the best and everything claims to be the best, then everything that comes along should be looked at with some skepticism.
Mm-hmm.
BFR is not a panacea. It's not going to heal everything. It's not applicable to every situation. It's something relatively new, but it is not as new as most people think. Yep. It's new to them.
Yeah.
It's difficult because I think most people, once they reach this level of influence over top level players and how they are treated or take care of themselves, they say, hey, 10 years ago, these stim units or Compex or Mark Pros or whatever, any kind of things like that, they said, oh, we'll shift your fiber type. We'll help you do this. And it turns out maybe it wasn't so true. but if they bought in, then they feel dumb because it didn't happen.
Yep.
And so now they're like, hey, what is this whole thing about? You're telling me that we can preferentially work on type 2 that hypertrophies faster. How can that be? In 10 years, I'm going to be kicking myself again. And it's hard for them sometimes to see something if they don't necessarily understand the physiology as well as we might.
Yeah.
Then I think that's the biggest thing that Kurt and Paul have harped on is it's the education and getting them to understand, like, hey, it's a real basic principle. If you can follow our reasoning, then and be consistent with it for, I mean, really as little as 2 weeks, you'll start to notice some changes as long as you're not one of those rare non-responders. But you'll start to get that buy-in if you get 6 to 9 sessions of consistency.
Right.
And it's something that I think if you can educate and be consistent for 3 weeks, you'll get the buy-in.
Yeah.
Agreed. I completely echo that statement. And it's all how we can educate our fellow colleagues, how we can educate and even our orthopedic doctors a little more. I know it took me probably 6 months or so, 5 months to educate, to at least get our doctor to buy in a little bit on it, which was great. He's all for it now. Funny enough, he just had total knee replacement, and he's like, oh, when can I get on the BFR? So like it's again, trying to get them just educated is the biggest thing for us. And then the courses you guys provide are great. They come in, you guys, your group comes in and provides great information and great feedback and stuff like that, and it really helps us then help other players or other colleagues to get education they need for the use of the device.
Cool. Appreciate it, Paul.
Yep.
Yeah, I'm going to elaborate on what both said. I mean, I'm going to echo what Paul said about the course. I think it was the way you guys lay out all the information. I mean, it is dense when it comes to the science behind it. Kyle did a really good job of kind of dumbing it down for us.
He's good at dumbing.
You guys are also very reachable. When we have questions or concerns or even anecdotal data or things that we see that we're doing. Kyle's easy to reach out to through text or email. Find out what he's doing, or get some sort of information from him in terms of how we can continually better us as practitioners, but also help improve our athletes' health status. And so it's been a really good adjunct, I think, for us. And obviously, we're all presented with new technologies and that kind of stuff when it comes to different companies coming at us and figuring out what works in our system. The biggest thing is how does it fit within your methodologies? I think that's a big thing, and almost doing it on yourself, being your own guinea pig or your own lab rat, and really trialing and kind of pushing yourself to the limits so that you have an understanding of what your athlete is going through, or gen pop patient. That way you can kind of describe to them how they feel. And honestly, like Reade said, after 6 sessions, after 2 sessions, these guys, they feel a lot better. They feel different compared to them having not done BFR before. And the buy-in is really easy. And not, again, to go all the way back and not blasting them with an 80% occlusion right from the get-go. Mm-hmm. It's just getting them used to that stimulus or uncomfortable feeling. And then every session, just pumping it up a little bit more until you get to the occlusion pressure that's desirable. Maybe 80% isn't going to work for someone. Everyone has different pain tolerances. And I think us in our situation, we have a really good understanding of our players individually, knowing who your softer ones are, knowing who your hard as a bat ones are, and then who you can push and who you kind of have to mosey on along with. So, it's been great to have BFR in our setting. And again, we try to use it as much as possible in all situations.
Nice. Yeah, that's great stuff. And then I think, just reaching back on Paul's thing, I think the physician buy-in is about to just be swayed. It's already very ortho accepted, but just the fact that at Academy this weekend, the orthopedic, the biggest conference they have, the AOSSM press release was all about the BFR ACL study that they were promoting, and Nova and Dr. Robin West group, the Redskins doc and the Nationals team doc, they had a huge, almost like a booth. It was a poster research presentation with videos about BFR, and they're pumping that. So if you're seeing a rehab thing like being pumped at the ortho conference like that, it shows us that these guys are getting, and girls are pretty excited about it, which I think is going to just make it much easier, not just for all of you guys, but everyone out there. So, kind of our wrap up here, where, I guess a couple of things, like where you see it going for soccer, because again, in the U.S. right now, of all the professional leagues, soccer's kind of our slowest kind of group that we're working with is a big group. Reade and I have been talking for years here, but kind of where you would like to see it going, where it's going. If you were to have the most ideal soccer study or thing, what do you think it would be with something like this? Because then I'm going to write up for a grant and take all the credit.
I would say, I guess it would be, we are kind of touched on it, the soft tissue stuff, the soft tissue injury, hamstring injuries. Probably one of our big injury numbered aspect of the sport. But also just having the ability to have a unit for every athlete, or something, get it along, and it's a financial thing, I get, but still just trying to get that player on it, trying to use it and getting them in a daily basis would be great. I don't know much after that. After that, just kind of, it's all, so the volume we can get, it's great.
And it's on workers' comp in the MLS as well, right? I know that's a kind of a touchy scenario, and different teams have different perspectives of that. But that really kind of took it overboard, I think, in these other professional leagues. What do you think?
Yeah, that's it. I think it's to jump on that. I think it comes down to if you can use it on multiple athletes, they're like, oh, hey, you can use this on other players and stuff like that. You don't need multiple units, I guess, in a way, but that kind of gets to the point where, like, again, it's a financial aspect of being in our league. We there's certain things that they want to cut down on, we need to cut down on, but again, we're just trying to get the best product on the field. Yeah. We're trying to make it more competitive, and the way we can do that is, innovative type of techniques that may help. Hey, great, let's do it.
Yeah.
So
I think something I'd be interested in going towards the future is the team setting, regenerative processes, and how we use it on our quote-unquote regen days. Mm-hmm. Typically, you have 11 guys or 10 if your goalie's not involved. Depends on what club you're with and if goalies are counted as players at all. Having enough units, or a unit that can supply multiple people, to where if you're doing a team regen on a bike, getting them all on a unit or on a system to help with the flushing of waste from a game or from obviously a match. But also even like post-career, obviously with all of our work comp cases, guys eventually getting OA and, your hip or your knee, ankle, depending on the surgeries they've had, and, longevity studies looking at, does BFR maybe in their current playing setting, does that minimize the effects of the toll of the sport or whatever later on in life? I mean, I can tell you, and Reade can we've had an athlete in common recently, and you could probably suppose he's going to have quite a bit of OA in both hips and probably both knees. And would it be a good thing for him to have at home for personal use, and when you look at what comp cases, at the end of their career, is it something that can be financially feasible for these guys to have? What sort of applicability does it have with shitty joints? I mean, soccer it's a rough sport on your hip. and your knees. Typically with us, we'll do a lot of baseline MRIs when guys come in, and we've seen a lot of things that are labrum FAI related that may be asymptomatic, but diagnostically they're there. Guys that will come into the club that may or may not have had any issues previously, they have some sort of chondral fissure and chondral defects that they did or did not know were there. Will BFR help them with that, with minimizing the issues they have in a season? It's a 10, 11-month season, depending if you're Seattle and you go far in the playoffs. It's maybe nice to have all these units around to help keep you healthy.
Don't you speak for yourself there, buddy.
I mean, you guys are off to a nice start this year, so. But I mean,
yeah. Thanks.
I think too soon. I think there's a lot of applicability with BFR, and I think there's a lot of ideas that us as a group have in terms of what we want to do with it. I mean, that's why we had you guys out at our PSAT meeting this year. I think we had 24 people that attended the course, and I think everyone had positive feedback because they understand kind of how beneficial it is. I think a big thing with this and with new technologies is listening to your peers. Reade was a huge proponent of this and kind of got me on it a few years back. And that's, when I tag teamed with the Lakers and they did theirs in-house session. And that's kind of where I got started with it, was because Reade is someone I know, I trust. And I think what he was doing was incredible. So I was like, well, why the hell am I not doing this and bring this into my club? Because it has a lot of benefit for everyone. So
right, that's good. What do you think, Reade?
Yeah, soccer is one of those things where it's not like you have the secret sauce for doing something that nobody else should know. It's cheating. It's we can't share this. It's top secret. Like hey man, like you said, we need the best product on the field. So I'm also a fan of, you don't need to be the best practicer. You need to be there on Saturday and occasionally Wednesday and Sunday. But if you think our preseason is so short, I see this being something that, I mean, ideally for me, if you could kick a ball twice a week for the first 2 weeks, and the rest is just working on getting guys out of off-season mode. And you use low impact exercises, BFR, you do 2 weeks of kind of like the walk studies. You do incline walk twice a day for 2 weeks. And all of a sudden now let's do some baseline VO2 tests. Now let's start to add in the real load. And then the next 2 weeks, we start to introduce real load. Then you kick the ball 3 days a week. And then you kick the ball 4 days a week. And then by the time that you get to the last 1 or 2 weeks of preseason, you're getting to a game speed. You don't have any of these acute to chronic workload issues because you just jacked everyone up into way too high of a load, way too quick. Yeah. And you're now ready for your 34 plus game season. And you have a good habit of maintenance 2 to 3 days a week. Right. So it's something where, I mean, 18's 18, you get 3 groups of 6, you get 6 pairs of units. You can knock this out in about 3.5 hours. You get good sessions. Yeah. And it's, as much as it is financial and numbers, just take some planning. Yeah. And I think that's where you can really build people up a lot in 3 weeks if you do it appropriately, especially after a long Seattle season, a CONCACAF push early in February, like things like that. These are the things where like people will laugh, but you'll start to see it. Yeah. And it's like other crazy things that people want to say, but it's something that it's going to come. Yeah. People will have chairs where they sit with a Compax on a program, and their BFR will be, coordinated to it. Whether it's iPad controlled by a clinician or not is far off, but I think it'll be everyone's chilling in a lounge playing the Xbox, and they're not really paying attention to the cuffs inflating and deflating. Yeah. 5 minutes, 1 minute, but they're going to hang out there for an hour anyway. Why don't we at least get them some active recovery where then they could play FIFA and bond with their teammate? Yeah. Yeah. Right back to your load management. I mean, it's all the way back to that. So yeah. And I that's probably where we're going to see
other than all the post-surgical stuff, which is all ongoing, we're going to learn a lot in the next few years, which will help with those players. But yeah, the recovery thing is huge. That's a lot of questions, and I think we're going to start to learn more and more just from the ischemic preconditioning alone. I mean, those papers are just coming out nonstop, and so we're going to see that from recovery and also from performance enhancement. Is there a pre-ischemic conditioning that somehow you enhance performance? So I think we'll get a lot of that, and then the soft tissue stuff. We have a hamstring trial going on at the University of Southern California, which is hoping to lead into a larger clinical trial with some pilot data. So that's probably going to be the future here. It might take a while, but hopefully this MLS collaborative, we get a lot of good information from you guys because you're the ones that are seeing it out in the trenches that can give us good feedback. Well, cool. Anything else, you guys? This has been great. I feel like I need to go kick a soccer ball.
I'm sure we can. The three of us can teach you how to do that, and we can just keep running you. He can be your fitness coach on that side of things.
Screw that. There's too much running involved. I'm done.
I'm waiting for people to start trying to do ultra training with BFR, but it'll come.
Yeah. Well, everyone's trying to run with them. I'm not sure if that's the best thing. If you can run. Do some down days. Get on a bike or walk with it just to deload yourself.
Correct.
I think the decline treadmill walks with BFR are the next thing.
Decline. Oof. All right.
Yeah.
Oh.
So,
All right.
okay. I'll just leave. I'll leave it at that. Cool. Anything else you guys want to add before we sign off here? It's been great, man.
No, I just want to say thanks a lot for having us on. I mean, it's just a small group of guys right now from MLS, but I'm sure we'll get a bigger group on at some point, and it'd be great discussion. And it's always nice to pick other people's brains and get information. It's great.
Tip of the spear right now, man. Lead the way.
I'm sure we'll have more updated cases next year, I'm sure.
Yeah. Well, look forward. Maybe we can get back together at the PSATs and talk again and get some more stuff to get some of these studies going. Is there an MLS-wide research grant, like the other leagues have that y'all know of?
I would say
maybe
no.
FIFA and Mark, but that would be the only kind of stuff.
Well, then it's just going to be do these little 11 exercises before a game type of thing.
Correct.
Well, cool. All right, fellas. I'll sign off here. Again, thanks for your time, man. I know it's valuable. Appreciate it.
Thank you for having us on. Appreciate it.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.